So for this lecture series, we're going to look at just two drugs that affect inborn errors of metabolism. So it's pretty simple. We've only got one learning objective. Describe the mechanisms of action and the clinical indications, specifically of carnitine and sapopterin dihydrochloride. The two disease states we're going to talk about are GA1 and PKU. Okay. So GA1 is glutaric acidemia, type 1. It's an autosomal recessive inborn error of metabolism that has a primary effect on the glutaryl-CoA enzyme dehydrogenase. So what does this mean? The biotransformation or the metabolism of three amino acids, lysine, hydroxylysine, and tryptophan, are going to be severely restricted. And this manifests itself as an accumulation of glutaric acid, which is really toxic, especially toxic to neurons, but also to various tissues and cells. And so to treat these patients, the first thing we have to do is restrict the protein. So they have to have a diet that is severely deficient in at least these three amino acids. And then also we have to supplement with micronutrients. And so the main focus is going to be this low lysine, low tryptophan diet. And a lot of these patients also fare much better when supplemented with carnitine. So carnitine is, remember, it's an endogenous carboxylic acid. It's a derivative of amino acids, but it has a main outcome or a main focus in terms of energy production, specifically at the mitochondria. And it's involved with fatty acid transport through the mitochondrial membrane complexes that basically evolve beta oxidation. And so you can review all that in the biochemistry course materials. It's found in meats and fish, and patients that have the GA1 deficiency need more carnitine. They are carnitine deficient. Their plasma serum levels of carnitine are extremely low. And so what we do is we supplement carnitine in the diet, and what this does is feeds into the biochemical pathways to reduce the buildup of this very toxic glutaric acid. Okay, and so that's kind of the justification for carnitine in the GA1 patients. Let's kind of switch gears and talk about PKU. And so phenylalanine hydroxylase is really kind of the main enzyme that we're going to talk about here. And so these patients, these PKU patients, either lack the enzyme or have deficiencies in the activity of the enzyme. In either case, they cannot convert phenylalanine to tyrosine. And so what we do is we supply this drug, sapopterin dihydrochloride. And what this does is it basically resembles the cofactor BH4. And so BH4 is this cofactor. You can see it in this enzymatic pathway. And so, a lot of these patients, they may have the enzyme, but it's not working well. And I have a nice graphical depiction of this. And so what this drug is this is kind of a BH4 mimic enzyme or cofactor. And what it does is that it enhances the catabolism of phenylalanine to tyrosine, which is great. It's orally administered. And we can see dramatic reduction in plasma levels of phenylalanine within 24 hours of the first dose. In terms of drug-drug interactions, there's a few that are out there. The main one I think that you should maybe focus on, at least because we're talking a lot about nutrition and biochemistry and metabolism, is that the folic acid antagonists like methotrexate, there is a well-known interaction there. There's a few other ones, but I don't think we need to discuss them at this point. And so this drug is under the brand name Kuvan, and it's specifically for phenylketonuria patients, and it has to be administered with a low phenylalanine diet. Otherwise, it doesn't really work that well. It's a tablet or powder. Powder is good, obviously, for young children. And this drug is indicated for adults and children as young as 1 month. So what you do is you look at kind of baseline levels of phenylalanine to see if they're, kind of 7.5 milligrams per deciliter is kind of like the cutoff. And then, of course, from that point on, we start monitoring these phenylalanine levels to see how successful the dose that we're administering actually is. And it's also indicated for this other condition called HPA, which is hyperphenylalanemia, which is similar but not the same as PKU. Okay, so this is kind of a nice schematic of what's going on here. So these are regular patients that don't have PKU. Here's phenylalanine. Here's the enzyme phenylalanine hydroxylase. Here's the cofactor BH4. And what they do is these together convert phenylalanine to tyrosine. In patients that have PKU, this enzyme cofactor relationship is not optimal, and so phenylalanine accumulates. Okay, and so patients do not convert as much phenylalanine into tyrosine, so you can see a reduction in tyrosine production, but phenylalanine levels increase. And this is problematic because then this can go into a different pathway and make some of these other phenylalanine-like metabolites that are phenylpyruvates, and some of these can become toxic. And then they also, of course, feed into other biochemical pathways which aren't listed here. So what this drug does is that patients that have PKU, it binds to this complex kind of right here, and it basically serves as a facilitator for a BH4 PAH type interaction. So I think of it kind of like a catalyst type relationship where it kind of lowers the energy threshold. What it does is it kind of restores the physiology here so that now these PKU patients can metabolize phenylalanine. So of course you see a increase in tyrosine production, similar to normal healthy patients, a reduction in phenylalanine in the serum, and few, if any, phenylalanine pyruvate type metabolites that can be potentially toxic. So that's pretty much how this drug works. Side effects: the main side effect with this drug include a constellation of symptoms that look kind of like the common cold. Less encountered side effects are listed here, and then of course the toxicities which would warrant medical intervention are listed here. Okay, so that's kind of a brief overview of two kind of drugs that are useful for treating some of the smallest patients with inborn errors of metabolism. This is just kind of a small sampling. Of course, there are many more out there, but this is what we're gonna focus on for this particular case. Here's the references. Hyperlink to some interesting papers about this topic, and of course, if you have any questions, you can email me or Dr. Sasabo in terms of the biochemical pathways. All right, thank you.